Keratoconus was first described over 150 years ago by John Nottingham. Over the past decades, refractive surgery has stimulated remarkable advances in basic and clinical research of the cornea. Ectasia occurs due to a process of biomechanical failure of the corneal stroma. Collagen and proteoglycans make up the majority of the substantia propria of the corneal stroma, along with a paucicellular keratocyte population, and in toto determine the innate biomechanical properties and resiliency of the cornea. Although a genetic predisposition to keratoconus has been observed, ectasia only occurs clinically due to a combined effect of genotype and external environmental stimuli. Chronic epithelial trauma from eye rubbing or poorly fitted contact lens wear promotes keratocyte apoptosis through interleukin-1 cytokine release, which is also associated with an imbalance of proteinase enzyme activities. Interestingly, a recent Korean study found significant differences in interleukin-1 gene haplotypes of keratoconus patients and control individuals. As genetic predisposition tests have not been developed yet for ectasia, the diagnosis is currently based purely on clinical manifestations. Classic biomicroscopic signs are the following: Fleischer's iron ring around the base of the cone, void stria on the posterior stroma that disappears with mild digital pressure, apical scarring, Rossetti's sign of the nasal conical reflection, Munson's sign of conical outward deformation of the lower eyelid on downgaze, and a scissoring reflex on retinoscopy due to irregular astigmatic optical aberrations. These signs are only present in moderate to advanced disease. From Helmholtz's ophthalmometer to Schiontz-Javel's keratometer, and up to the first Placido disc photokeratoscope developed by Nobel Prize winner Alvar Goldstrand, there was remarkable evolution in the diagnostic techniques to characterize corneal shape over the last century. Mark Amsler improved photokeratoscopy for clinical documentation and described mild corneal distortions prior to the development of other clinical signs, and referred to these cases as form-fruste keratoconus, either an abortive form of ectatic disease or an attenuated presentation of the disease. Thus, form-fruste keratoconus does not specify if progression will occur. It was not until the advent of keratorefractive surgery in the early 1980s, however, that corneal analysis attained its great momentum. Steve Kleiss popularized the use of color-coded maps from the computerized keratometric data, and along with Yaron Rabinowitz developed quantitative indices for identifying normal and ectatic patterns. Such indices were found to be sensitive for detecting abnormalities in some cases with relatively normal visual acuity and no other signs of ectatic corneal disease. The detection of subclinical ectasia is critical when screening refractive surgery candidates. While risk factors are well described and scientifically validated, mysterious cases of post-keratorefractive surgery-related ectasia without identifiable pre- or perioperative risk factors support the need to go beyond front surface topography and central corneal thickness. An enhanced approach using corneal tomography and non-invasive direct corneal biomechanical testing has recently been proposed. For example, this patient had unilateral LASIK and then developed ectasia with no detectable risk factors. The contralateral unoperated eye, which was stable for over 10 years, would be considered a good candidate for LASIK surgery too, based on standard screening criteria. However, tomographic indices based on elevation and pachymetric distribution and direct biomechanical measurements found what we refer as subclinical ectasia. Similar findings were observed in over 90% of contralateral eyes with normal topography of patients with keratoconus in the other eye. Corneal tomography describes the evaluation and data acquisition measurements that provide a three-dimensional reconstruction of the cornea. Epithelial thickness measurements are also promising for ectasia diagnosis, since epithelial modulation may mask mild ectatic changes on the front surface. Tomographic characterization of the thinning pattern is critical for classifying the ectasia. Whole eye wavefront aberrometry allows for understanding the visual impairment related to ectasia, has been valuable for enhancing manifest refraction and also for designing custom glasses or contact lenses. Although optical aberrations are useful for diagnostic purposes, these generally are late findings due to irregular corneal shape changes from the underlying process of biomechanical failure. Clinical assessment of corneal biomechanics represents a real cutting-edge advancement in technology to assess the structural properties of the cornea. The integration of biomechanical and tomographic data currently provides the most complete diagnostic platform for ectasia detection. The importance of improving the sensitivity for diagnosing ectasia, in addition to assessing the risk for the progression, is a critical consideration in the management of such diseases. Major advances in corneal surgery have not only improved outcomes, but revolutionized the concept of surgery for ectatic diseases. Corneal collagen cross-linking was introduced by Seiler and co-workers in the late 1990s as a procedure to biomechanically stabilize the cornea, preventing ectasia progression and visual loss. Until the late 1990s, surgery was indicated exclusively to improve vision when glasses and contact lenses failed. Penetrating keratoplasty was the primary surgical option. Developments of deep anterior lamellar keratoplasty techniques allow for similar visual outcomes as in penetrating keratoplasty, with important advantages of retaining the patient's own endothelial cells. Also, the femtosecond laser has revolutionized the precision and accuracy of corneal surgery, providing the ability to create customized cuts for penetrating or lamellar keratoplasty, as well as tunnels for the implantation of intracorneal ring segments, introduced by Collin and Ferrara using manual dissection techniques in 1994. Other procedures, such as customized surface ablation and phakic intraocular lenses, have been found useful in the management of keratoconus. Different combinations of such procedures are effective, such as the Athens protocol described by Kanopoulos, combining customized surface ablation and cross-linking in the same session. The decision if and for which purpose surgery is indicated should be individualized. The trend is not only to postpone or avoid keratoplasty, but to be less invasive and intervene earlier in the disease process, not only to restore vision, but to prevent visual loss. Patient and family education about the disease play an important role when managing ectasia patients. Considering that there are more accurate diagnostic techniques currently available, and that the ability to halt the progression of the disease is commercially available in most countries, every ophthalmologist should be alert for screening for such conditions when evaluating young patients. As in evaluation and management of glaucoma in diabetic patients, early diagnosis and appropriate early intervention for ectasia patients should be able to prevent visual loss. These facts, along with the relatively high incidence of disease in the general population, has made an unmet niche for the ectasia subspecialist among corneal surgeons. Thank you for your kind attention.